This year presentation I presented some thoughts about challenges in the future when combining anti-PD1 and anti-CTLA4. I think there is a misconception that these two antibodies are hitting the same cells or having the same effects, and I tried to convince the audience that we should combine this. We don't know yet convincingly how we should combine it and what they are exactly doing. So first of all, we have to define the patients that really benefit from monotherapy long-term versus the patients that are really in need for combination therapies. I believe that, and this we have learned now from the 067 data, that for example, patients that are PD-L1 positive, they don't benefit long-term in their overall survival from the combination therapy. And these PD-L1 positive patients are the typical patients that have a good prognosis. They have already a good ongoing immune response against the cancer. So in that way, we first have to define patients that have benefit from monotherapies and then define patients that are in need from combination therapies. And the third group of patients are these patients that will not have a benefit from the combination therapies. And then we have to understand how we have to modulate the tumor microenvironment to give them the chance to have long-term benefit. That's indeed the same way. If you're a patient that has a very good intact immune system, you might have benefit from a monotherapy, and we might even overdo it if we give harsh combination therapies. We induce adverse events, and we might induce even activation-induced non-responsiveness. So even bringing this immune system to a sleeping modus. So in that way, it's indeed also very important to think about the adverse events as a signal of breaking the peripheral tolerance and overactivating the immune system. Yeah. So currently we have just published the NKI scheme. That's a scheme where we upfront started with anti-CTLA4 and then switched at once to anti-PD1. I'm still looking for financing of such a trial to compare to the standard regimen. The interesting data of this trial were that this are retrospective data, where that we observed the same response rate, even that the population that we treated was worse than in the 067 trial, and despite of that we had less toxicity seen. So in that way, this might be the way to go to play around with sequencing, gradual overlapping of different antibodies, reducing the toxicity, improving the efficacy.